Hello, and a very warm welcome to today's ISNTD Connect. We're going to be talking today about snakebite and envenoming. Now, my greatest wish to start this session would be to give you some very strong statistics, some very compelling data about the extent and the burden of snakebite. Unfortunately, the epidemiology of snakebite itself is pretty sparse. The data is sparse, and so perhaps that in itself is a compelling fact towards the neglect of this condition worldwide. What we do know is that annually about 5 million bites take place, of which up to 3 million result in envenoming. Sadly, many of those will result in fatality, anywhere between 25,000 and 140,000 deaths a year. And where persons affected might not succumb to their wounds, unfortunately, they are very often left with severe sequelae and leading sometimes to amputation. So a really serious condition that affects many rural populations engaged primarily in agricultural work, in general communities that were already to begin with very vulnerable. So tackling this issue worldwide really is a priority amongst all the neglected conditions. And if there's one thing that's become apparent is that the early and accurate assessment of a snake bite and of such a wound is really primordial for the outcome for the patient. Quite a number of studies have come out recently, again pointing to the fact that healthcare workers are sometimes inadequately informed. They often can overestimate perhaps their knowledge of wounds. And so really any tools that can be brought to such healthcare workers as early as possible in the evaluation of a patient can only improve outcomes in these circumstances. So today, we are really delighted to be joined by Dr. Tamilarasu Kadiravan. Hello, Kadir.
Hi.
Thank you so much for joining us. Dr. Kadiravan, you're speaking from the Jawaharlal Institute of Postgraduate Medical Education and Research in Puducherry, India. It's really nice to have you with us here today. And sorry.
Yeah. I think you please continue.
Thank you. And we're really excited because you are going to speak to us today about some really innovative work to help with all the issues we just sort of outlined in very broad terms. And you'll be showing us some of your work in a point-of-care infrared thermal imaging system to assess snake bites in those early stages that we just spoke about. So without any further delay, Kadir, I think I will hand over to you for you to give us a bit more insight into your technology and into your approach. And hopefully, dear attendees, after Kadir's presentation, we'll be able to take some of your questions and have a really good discussion about this approach and its applications in snakebite, but also maybe across other diseases. So very warm welcome to you, Kadir, and just a very quick hello to some of our attendees. I can't mention everyone, but we're joined here today by Shiraz Raja, hello, Kurt Rittmeyer, nice to see you here, Louise Kelly-Hope, Akwawa Oroko, welcome, Adrian Hopkins, Vincent van der Velde, and many, many more. David Williams, hello. So lovely to see you all here, and I'll hand over now to Kadir and see you in a few moments after the presentation to take any questions. Thank you very much.
Thank you, Marianne, for the kind introduction. And good evening, everybody. Before I proceed further, I would like to thank the International Society for Neglected Tropical Diseases for this wonderful opportunity to share our research findings with a broader audience. We think that this opens up a new area of investigation in the way we diagnose and treat snake bites. As Marianne was alluding to, the snake bite envenoming remains a neglected tropical disease. Only recently in 2018, the World Health Assembly formally recognized snakebite envenoming as a neglected tropical disease. And every year, nearly about 3 million people bitten by snakes develop envenomation, and resulting in about anything upwards of 100,000 deaths every year. And most of these envenomings and deaths happen in the underdeveloped parts of the world, including South Asia, Africa, and Latin America. India contributes almost anything anywhere between 1/3 to 1/2 of all the snakebite envenomations encountered globally, and every year about 50,000 people succumb to snakebite envenomation in India. This comes to a lifetime risk of about 1 in 250 people in India die before the age of 70 because of snakebite. And in certain parts of India, the risk is even higher than 1%. The absolute risk is more than 1%. So when we try to understand the risk of the vulnerability to snakebite envenoming and its consequent effects, we can try to understand it by triangulating how different factors, risk factors intersect. That is basically where humans inhabit places in which cohabited by venomous snakes. The problem gets exacerbated by various factors, like there is no availability of effective antivenom, and there is no ready access to healthcare in general, and the quality of good quality healthcare particularly. When all these risk factors align, the population becomes particularly vulnerable to the ill effects of snakebite envenoming. That way, if we see, hardly about 6 to 7 million of nearly 1,300 million population living in India would fall under the vulnerable category. But the magnitude of the problem which we encounter in India is totally disproportionate to that. So we really can't explain the entire problem, the problem in its entirety, by these 4 factors alone. There are several other factors which would perhaps explain why the burden of snakebite envenomation is intolerable. One of the important factors, which is often not appreciated, is the fact that to date, the diagnosis of snakebite envenomation remains a clinical exercise, and the criteria for antivenom treatment is essentially based on thorough clinical examination. And if at all we do any test, it is this time-honored whole blood clotting test. There is no doubt whole blood clotting test has saved thousands and thousands of people worldwide. It's very easy. It doesn't require much of the resources to do it. It can be done under any situation, even in the remotest possible setting. It can be done. However, even though it is simple, it is fraught with the problem of false positivity. And there are people who say that it's even insensitive. It delays the initiation of appropriate antivenom. Leaving that aside, the only important problem which really brings down the value of the whole blood clotting time is the issue of false positivity, in the sense that when somebody is found to have an abnormal whole blood clotting test, when there is no envenomation, then they end up receiving antivenom which is otherwise not indicated. And we must bear in mind that antivenom is a scarce resource which is already in short supply all over the world. In places like Australia, we have access to what's called the snake venom detection kit. But we must remember this snake venom detection kit can be used to decide upon which specific antivenom has to be chosen to treat a given patient. It cannot be used to decide whether to use antivenom or not. Recently, a very exciting piece of research which came from Madhurage and colleagues from Sri Lanka. They worked in Sri Lanka, and they reported that secretory phospholipase activity in the blood of patients bitten by snakes could discriminate between those who are envenomed from those who are not envenomed across the species, because this secretory phospholipase is not species specific. It is found in multiple species of snakes, and for that matter, other venomous animals as well. So that's really an exciting piece of information. But unfortunately, back-to-back, very recent papers have come. We show that although the secretory phospholipase activity has high specificity in identifying people who are envenomed, often well before the signs of envenomation appear, its sensitivity seems to be limited. So there are problems about with the sensitivity of secretory phospholipase assay to diagnose snakebite envenomation. As of now, it still remains as a research tool. So what took us to consider using infrared thermal imaging as a diagnostic tool to diagnose snakebite envenomation? Truly speaking, we were not really looking at it. Rather, what we were doing or what we were interested in was using infrared thermal imaging to assess the progression of swelling over a period of time in patients with local envenomation following snake bites. That's because we are really trying to find an objective tool to quantify the progression of swelling, which can be used as an endpoint for endpoint assessment in clinical trials. But when we were pursuing this very interesting paper from Medeiros from Brazil got published. Essentially, they described 3 individuals. The first one was bitten by Bothropos munini, and the patient had local envenomation, and there was increased local temperature which was picked up by infrared thermal imaging. Obviously, whenever there is inflammation, the skin temperature goes up, it gets picked up in infrared thermal imaging. There is nothing great about it. Similarly, there was another patient, second patient, bitten by a crotaline snake. Even though there is not much of inflammation, swelling was not there, there were thermal changes which are apparent. Most interesting was the third patient who was bitten by Bothropos jararaca. This patient had what we call as a dry bite. Bothropos jararaca is a venomous snake. However, the particular patient did not have any signs of envenomation. And interestingly, when this patient underwent infrared thermal imaging at the time of hospital admission, there was no evidence of increased local temperature. So, in fact, it was Medeiros who proposed that we should perhaps be using infrared thermal imaging as an alternative way of picking up dry bites early. So we carried from there on. But the problem is that infrared imaging is not an easy thing which can be done at the point of care. It needs really a high, what Medeiros et al. They used a really high resolution thermal camera, which is very costly, prohibitively costly. And the infrared thermal imaging needs to be done under a very controlled climate environment. The room temperature has to be very well controlled. The thermal emissions have to be controlled. Like there are so many stringent conditions for a good quality infrared thermal imaging. So that really kind of does not make it appealing to use it under field conditions. However, with advances in technology today, what we have are small devices, very compact devices, smaller than highlighter pen, which can be attached to a mobile phone, a smartphone, and they can be used to capture the images. This is what we used in our study. So over a period of about 13 months, we are located in the southern India, the place Puducherry, it's a union territory. We studied consecutive patients who present to the emergency room, and this part of the world is the most important venomous species which we encounter in this part. Are mainly 4: Russell's viper, soft-scale viper, common kite, and spectacled cobra. These are the major venomous snakes. In fact, the only medically important venomous snakes encountered in this part of this world. So we encountered adults. We enrolled adults who were admitted, presenting to the emergency room with alleged issue of definitive snake bite within 24 hours of bite, and we excluded patients if they have already received antivenom before presenting to the emergency room. They underwent a thorough local clinical examination to look for signs of local as well as systemic envenomation. All of them underwent a whole blood clotting test, and if the whole blood clotting test was normal, a prothrombin time estimation was also done. And at the time of presentation, infrared imaging was done at the point of care, right at the bedside. Then, if there was no envenomation, evidence of envenomation at the time of hospital admission, they were re-evaluated 6 hours and 24 hours later. And at this point, all the clinical examination as well as the infrared thermal imaging were redone. And if patients showed no signs of envenomation, even at the end of 24 hours, they were discharged home. And those patients who showed signs of envenomation, they were subsequently imaged every day to look at the progression of swelling. So this is how the device can actually capture images into both visible light range as well as an infrared thermal range. So the second one is the unprocessed infrared image, which is obtained using that camera. But that you find a lot of thermal glow around the limbs. That needs a little bit of processing, as shown here on the third image, where you can adjust the lower limit of the temperature so as to eliminate the thermal glow around the limb. That makes it easier to appreciate the anomaly between the thermal temperature difference between the two limbs. This kind of acquiring images of two body parts, bilateral body parts under the same conditions, and comparing to the contralateral side, it's called a comparative qualitative thermal imaging, infrared thermography. Basically, it's less exacting in terms of technical requirements. You really don't have to use a very much stringently temperature controlled environment. It can be done at the point of care. That's because we are really not interested in measuring the absolute temperature. Rather, what we are interested in is relative changes in temperature. And the processed images, we can use some measurement tools to measure the maximum temperature in the area of interest for comparison. So over a period of 13 months, we screened about 92 patients, and finally we enrolled 89 patients. And of these 89 patients, 48 patients had evidence of local with or without systemic envenomation. In 25 patients, there was no evidence of envenomation. In 6 patients, the envenomation status was unclear, in the sense that they did not have any evidence of local or systemic envenomation, except that they had abnormal whole blood clotting times. And normally, we would do a prothrombin time to confirm whether this isolated prolongation of whole blood clotting time is true positive or false positive. Unfortunately, in 6 patients, prothrombin time estimation could not be done. Therefore, we could not come to a conclusion whether the isolated prolongation of the whole blood clotting time was truly abnormal or it was a false positive result. So here I have kind of chosen typical images. These are all 3 different patients. The first one on the left-hand side is a lady who was bitten by a cobra 2.5 hours before on her left foot, and we see a clear-cut area, hot area. Hot areas will show up as a red, and the maximal temperature area will show up in white. That's how it's color-coded. It's just a pseudo, we call it pseudo color coding. These are not true colors, these are pseudo color coding the thermal changes. So we see how the whole left leg is hot, warm. And the second patient was bitten by Russell's viper on the right foot 2.5 hours back. And again, we see an area there, the whole of right foot, there is increased temperature, and which is extending into the right leg as well. The third patient was the species of snake was not known, and the site of bite was on the left foot. And again, we see a corresponding area of increased temperature. So these are 2 patients, one bitten by a cobra and the other one bitten by a Russell's viper. However, these patients, even at the end of 24 hours of observation, exhibited no signs of local and or systemic envenomation. This is what we call dry bites. And we noticed that this patient who was bitten on the left wrist area, there is no corresponding increase in temperature compared to the right wrist. Similarly, this is the other patient who was bitten over the right ankle area. There is no corresponding increase in temperature as compared to the left side. And if we see the first patient, actually there was no swelling, there were no systemic manifestation of envenomation. However, there was isolated prolongation of whole blood clotting time, even though the prothrombin time was normal, with the report became subsequently available. However, based on this whole blood clotting, and this patient in fact was treated with 10 vials of antivenom, which retrospectively it becomes very evident that the whole blood clotting time was a false positive. So this is a serial imaging which has been done in a patient with a cell bite who was bitten on the right foot 8 hours before presentation. At the time of presentation, the area of increased temperature is apparent in the right foot and the lower half of right leg. And over the next 8-12 hours, the area of increased temperature ascends up to the level of the knee, and over the next day it crosses the knee, and by day 3 it has reached the level of the groin. And over the next few days, the temperature starts coming down. That's how it goes in the resolution. But interestingly, the part where the bite occurred, that is the right lower leg, still remains warm. Usually that is not the case, but in this patient it so turned out that this patient actually developed a local abscess with methicillin susceptible Staphylococcus aureus at the site of bite. That is perhaps the reason why the site of bite remained warm even after day 6. Here is an interesting image from a patient who was bitten 13 hours ago. The snake species was not known, but at the site of bite, there were 2 fang marks and there was bleeding from bite marks. If we ask anybody to guess on which limb, whether right side or left side, this patient was bitten, then I will not be surprised if most of you say that this patient was bitten on his right arm. Rather, this patient was actually bitten on his left arm. So what we observe here is there is, instead of an increased temperature, there is actually a paradoxically lower temperature in the area of bite. So this kind of paradoxical thermal changes we observed in few patients. This patient did not develop signs of any sign of envenomation even at the end of 24 hours. So technically he had a dry bite, but he had a so-called cold spot at the bite site. So to consolidate what we found, so of the 89 patients, there were 48 patients who had evidence of clinical envenomation. 35 patients did not have any evidence of clinical envenomation, and in 6 patients, it was unclear whether they were truly envenomed or not. Of those 48 patients, the hot spot was evident at the time of first evaluation, at the time of hospital admission, in 45 out of those 48 patients, whereas hot spots are evident in only 6 of the 35 patients without any evidence of envenomation. And interestingly, even in those 3 patients with envenomation who did not exhibit hot spots at admission, actually they had area of paradoxical thermal change, what we call as a cold spots at the time of admission. So if we calculate the traditional measures of diagnostic test accuracy, it turns out that the infrared thermal imaging at the time of hospital admission has sensitivity of about 94% and a specificity of about 83%. So when we did a sensitivity analysis in which we presume that patients with unclear envenomation were actually truly envenomed, even then the sensitivity remained at about 87% and specificity was not changed. So it looks like that presence of a hot spot has a good, absence of hot spot has a good negative predictive value, that is to rule out envenomation. And we were, since this is a new imaging modality, we were really interested in assessing whether what is the inter-observer variability, and within observer whether the rating is stable over a period of time. And we found that the inter-observer variability is really good, and within observer test reproducibility within observer was really excellent. And using the box measurement tool, when we measured the temperature difference between the 2 limbs, that is the bitten limb versus the limb which was not bitten, we should notice the point that the difference in temperature rarely ever exceeded 3 degrees Celsius. This is important because human skin, even trained observers have difficulty in appreciating thermal differences lower than 3 degrees Celsius. Even observers who have been trained to make subtle differences in temperature, they really have difficulty in appreciating temperature differences which are lesser than 3 degrees. But whereas this infrared thermal imaging is able to nicely bring out these changes in an easily appreciable fashion. So, what makes infrared thermal imaging better than clinical evaluation? It's very easy to tell, okay, fine, you are looking at local changes, you look for size difference, and you look for local warmth. Why should you need infrared imaging at all? So, the importance is that immediately after or in the early hours after following a snake bite, it's really not that easy to make out whether a subtle swelling is there or not. We are really not sure whether the swelling is present or swelling is not absent. And similarly, making out, as I said, temperature differences less than 3 degrees Celsius, which is usually the case, the human skin, where human perception doesn't have that much amount of discriminating power. Whereas infrared thermal imaging has a thermal resolution of 0.1 degrees Celsius. And more importantly, with our hands, where perhaps we can touch 4 or 5 spots on a limb and try to make out, whereas the infrared images which have a spatial resolution of 160 by 120 pixels. So really, thousands of points it's able to obtain measurements. And more importantly, if the images are kind of objective, we can record them, we can get them reassessed by somebody else with good agreement. That's what makes infrared imaging more appealing and more sensitive, more reproducible than our traditional clinical evaluation to evaluate for the effects of local envenomation. So, what could be the potential clinical application of infrared imaging in clinical practice? I can say that if infrared imaging is normal at the time of admission, then we can be reasonably sure that the bite was a dry bite. If we know that the identity of the snake is actually a venomous snake, we can be certain that it is actually a dry bite, even though the species is venomous, or else it's a non-venomous snake. But when we find a hot spot, we just know that the venom has been injected into the local site. We really cannot say whether systemic envenomation is present or not. Nonetheless, we can identify a group of individuals as a high risk of developing systemic envenomation. So when somebody presents within a few hours of a snake bite where you don't know the identity of the snake, when we do an infrared imaging and see absolutely no evidence of any thermal changes, we can be reasonably sure that whether that is a dry bite or a non-venomous bite. But if there is evidence of increased local temperature, then that individual has to be treated as a high-risk individual for developing features possibility of systemic envenomation. So it's likely to be useful as a very good tool for triage purposes. Similarly, when we encounter situations where there is absolutely no effect of local or systemic envenomation, but the whole blood clotting time is prolonged. So when there's basically when we suspect false positive whole blood clotting test, then also the infrared imaging could be of use to resolve the dilemma. But there are certain unanswered questions. Particularly, we should know, we are yet to know how early these thermal changes become apparent. So that is important because if you want to use in primary care settings, we should really know how early these changes become apparent. So that will help us to decide whether this can be deployed in primary care settings to aid clinical decision making. And there are certain species of snakes, particularly elapid species like crane, coral snakes, which do not cause much of local changes following bites. And in this study, we did not have a fair representation of these species. So it's important to know what happens in bites by cranes and bites by non-front fat colobroid snakes, which are traditionally considered as non-venomous, but some of them are medically important. And we observed some patients without any evidence of clinical envenomation, but however, there was evidence of increased local temperature. What is the clinical relevance? Whether it really brings in a paradigm of subclinical envenomation, or whether it we really have to rethink about the biology of clinical envenomation, and why paradoxical thermal changes are in some individuals. Why instead of developing elevated temperature, why in some individuals there is a paradoxically decreased temperature at the site of bite? What is the mechanism responsible for it? We need to explore. And perhaps more provocative, it's more speculative, is the possibility whether infrared thermal imaging could be used to recognize local complications following snakebite, like infection, like an abscess, or for that matter, when somebody is developing compartment syndrome. So, whether infrared thermal imaging could flag the development of complications. These are all unanswered questions before which need to be resolved in future studies. But whatever said and done, one thing becomes very clear, that we need a good diagnostic test to help people to diagnose and decide on whether somebody is used to be treated with antivenom or not. In a related sense, there is a very nice book written by Iruka titled Divining Without Seeds. She talks about diagnostic insufficiency. That is, there is something like somebody trying to treat a bone fracture without taking an X-ray, without obtaining an X-ray, which we would rarely ever do. That is similar to in the local context. He alludes to a guru or diviner trying to offer a cure without having access to his seeds, which he throws and takes a look at and tries to predict the future. In the context of infectious disease, this situation is perhaps restricted to Africa, but in the context of snakebite, it appears that the majority of the world is grappling with such a situation. So we really need a good diagnostic test to aid clinical decision making. That's a point I would like to emphasize. So before I conclude, I would like to acknowledge the contribution of my colleagues and my students. Sabita was my doctoral student, and my colleagues Chanavirappa, Deepanjali, and Surya Narayana, who helped me with this work in validating this data. And above all, I thank all of you for the patient audience. Once again, International Society for Neglected Tropical Diseases for giving this wonderful opportunity to share my findings with you. Thank you. Over to me.
Thank you very much, Kadir. That was really interesting, really fascinating. I just want to apologize. Some of our attendees had a crackling sound on the line. I personally managed to fix that, but if anyone wants to kind of review some parts of this presentation, please just drop me an email or a line. We'll have a recording as well, so apologies for that. But other than that, really enlightening, something that at this stage, any kind of new intervention in the treatment and assessment pathway is certainly very important and worth investigating. Kadir, obviously, you've elicited quite a lot of questions. I think people are wondering how this technology can be included in kind of a much wider drive to improve the awareness and the kind of the capacity of those frontline healthcare workers, those seeing the patients for the first time. And so maybe that's where we could start in terms of the discussion. You've given us a great overview of the application in a very technical sense, in a very practical sense, but how would you envisage now moving forward integrating this into those sometimes quite remote or those primary healthcare centers?
Yeah. So the thing is that whether is it feasible to do these things in a resource limited setting. One of the most important thing is the prohibitive factors is the cost of it. So this device, it costs about $300 US or so, but it doesn't need any consumables. You can just attach it to a smartphone, which is rather easily available nowadays, and it can be reused any number of times. So if you work out in terms of per patient cost of imaging, when it can be reused multiple times without getting used up, per patient you will be spending less than $1 US or so. But even in many of the situations across the world, even that $1 could be prohibitive. I understand that. But the antivenom which we use for treatment is much more costlier. Typically, in our setting, if you use antivenom for a patient, say 20 vials, that alone, antivenom alone costs about $70. 70. That gives a kind of sense of comparison for that. So the antivenom is more prohibitive. So if we can reduce the wasteful use of antivenom by doing this, then that will be really a kind of of course, it will be cost saving, but at the same time, you will be able to save this pre-disease antivenom to be used to a more deserving patient, a patient who really requires it. That's what is it. So I see a question there from Stephen.
Yep.
Asking about false positive data. Is it not safer to treat all bitten people with antivenom? So the thing is that antivenom is in serious short supply. So we really can't afford to do that. It all depends upon availability of antivenom. And at the same time, antivenom has its own problems, anaphylaxis, all those side effects. So both in terms of availability, affordability, as well as in terms of safety, it may not be advisable. But there are, I understand that there are certain parts of the world where when you know that that somebody has been bitten by a highly venomous snake, they do not wait for signs of envenomation to develop. They straight away go and give the antivenom. But there are kind of places where they can afford to do that. But in majority of the world, where you see most of the cases of snakebite envenoming occur, we can't afford to do that. That's a stark reality.
Well, I do have some good news, Kadir. I was once at a meeting and Dr. Jeremy Farrar, head of the Wellcome Trust, a major funder who's come into this space now. I don't think he was referring specifically to snakebite and snakebite envenoming, but he did say that, you know, have a great idea and a good invention, and then there will be a way to find the funds. So that was really interesting, the comparison you gave us in terms of costs. And so the good news is that one of the major funders does believe that if this is the right idea, then the funds will follow. So that is good to know. So in terms of partnerships, what are some of the ones you would like to see strengthened? You've covered a lot of issues and a lot of the gaps that are kind of common to tackling snakebite in every country, in every continent. What would you like to see more of? Obviously, you're coming from perhaps a technology and diagnostic side, as well as a health systems kind of thinking. So where would you see the priorities?
So the priority is that as of now, of course, we need effective antivenoms. The antivenoms which are currently available are not that really potent. They are highly variable in their potency. And even those antivenoms which are available do not cover many of the venomous snake species. So a whole lot of things needs to be done in terms of making antivenom a credible treatment. So whatever antivenom we have today is manufactured the same way it was done, say 150 years ago. There is no standardization, there is no consistency, and there is, so what is manufactured in one area might not be really effective few hundred kilometers away, because there is so much of variation. So now only people are trying to using new tools to understand the variation in venom and how to develop suitable antivenoms to tackle this variation. That's one part of it, getting the science right. That's one part of it. Second part of it is from a health services perspective, how to, even if we have an effective antivenom available, but how are we going to make it available to a person who really needs it the most, which is often in a very remote locale, which is inaccessible, and within where hours really matter, within an hour or two following snakebite. How are we going to make it available? That's a huge challenge actually. And the third thing is what I'm talking about is that whether diagnostic, bringing in reliable diagnostics can really help us to use antivenoms in a more focused, more precise way where it's really needed, and at the same time avoid wasteful use of precious antivenom. So there are different dimensions to it, and these are the three things which I can readily think of.
Fantastic. Well, today, Hadir, you're mostly talking to a neglected tropical disease audience, and of course, snakebite is listed within the official NTD list at WHO, but so it sometimes feels as though it falls in this kind in between two things. It is under the umbrella of something as as established and substantial as the NTD label. However, some of the snakebite community might say that within NTDs, it's always slightly considered as a somewhat different NTD, that, it doesn't have a mass drug administration campaign, of course, and all sorts of things. So is there something more that the NTD community could do to perhaps integrate tackling snakebite as part of other programs? I'm thinking maybe approaches that are looking at skin conditions or healthcare messaging, or this kind of community engagement programs and approaches.
Yeah, community engagement is very vital in the sense that access to healthcare. This is where snakebite is where traditionally these communities, they do not seek healthcare even if it's available. Many of them resort to traditional healers. They try the traditional medicines like local plants and based on their local beliefs. So they, even in places where there is access to quality healthcare is available, still many of those people do not seek that. So there whole lot needs to be done in terms of addressing the healthcare seeking behavior of populations. So the populations at risk have to be engaged. So that's very important, educating people and the populations at the local level, taking into consideration the factors which play in the local context, trying to address them effectively. That's very important. Otherwise, these things simply, they are not going to work. If patients don't seek care, then it's going to be really difficult. And we know that the pre-hospital care they seek, it has a direct bearing upon the outcomes. So that's very important.
And how prevalent does kind of traditional healing methods, how prevalent are they still when it comes to snakebite?
It varies from place to place, and it all depends upon whether you are looking at a peri-urban population or you are looking at a far remote tribal population, tribes which live. So those places, it's where kind of traditional methods of treating snakebite is the norm. But that's not the case in areas which are in the peri-urban or something more urbanized areas. That is different. So it all depends upon which population you are looking at. So it has a very strong local context. That's very important.
That's really interesting, and kind of building on that, and we were just talking about partnerships a few minutes ago. There's been a comment and a question here from Dr. Ivana Haluskova-Balter, who's asking about maybe partnerships with the African continent or with other countries. And of course, one of the challenges there is the types of snakes in different areas. So although these barriers exist, are there international or intra-regional partnerships that could be explored and strengthened a bit more?
Yes, this is very important. Given that the variety of venomous snake species we see on the earth, they are so diverse. It's very important that if at all we want to use this as a diagnostic technique, we really have to use it in a particular type of snake species and see what happens. So it is very important that this diagnostic technique is studied in local settings with the kind of venomous species they encounter, and it has to be validated. For many times it might work, and it's quite possible that, as I was mentioning, there may be some elapid snakes like coral snake. We do not know what happens actually. So it's very important that it is validated, it is tested and validated in a broader range of geographical fields involving multiple different types of snake species. That's very important. That only truly a global effort on a larger scale only can kind of bring out such a thing.
Got that. Stephen Bramer here, tuning in from Canada, had another question. Have you observed any other types of thermal signals that are associated with specific venoms?
Oh, I am actually not getting the question correctly. So one thing is that we had elevated temperature, and there were some patients with a paradoxically lower temperature. But when we try to look at the way how the local inflammation progresses, there seems to be a pattern in the sense that the way the thermal changes happen, it doesn't happen as a kind of a wave kind of thing. Rather, it seems to be spreading along the lymphatics, okay, in a linear fashion along the lymphatics. So, but that's too preliminary. We really don't have much data, but it looks like that. We know that snake venom gets absorbed through lymphatics. So many times you will find that from the site of bite, the temperature change extends like a streak across along the length of the limb, rather than as if it's painting. That's one thing. Other thing is that how the inflammation comes down is also very interesting in the sense that something is bitten here, say finger, then it ascends up, but by the time it ascends up, this area where it was bitten starts becoming less and less warmer. It loses heat actually. So it's as if kind of a forest fire, it spreads. There is a front where everything is burning, but it leaves behind a burnt tree or a burnt soil behind. Something like that. It happens actually. So basically, it's a kind of a front of inflammation which moves on from the site of bite. So these are all some patterns which we observe, but these are all really preliminary observations, and we have hardly 89 patients or so. These are too preliminary, but it seems to be, and much more things might come. We do not know. And for that matter, Medeiros, they have described in patient with coral snake bite. The patient was bitten on one hand, whereas within minutes, the patient actually showed thermal changes in the contralateral hand, not contiguous thermal changes. So a whole lot of interesting things seem to be happening. When we start trying to visualize things which we cannot see with ordinary visible light, then we get to realize a whole lot of invisible things which go on in our world. So it's possible that much more patterns of thermal changes are uncovered in future.
It's got that. That's really interesting. One thing that springs to mind, I suppose, an issue that is brought again and again when it comes to patients presenting with snakebite is the perhaps lack of confidence in the healthcare workers, the healthcare providers, in assessing the situation. So there's a gap there, certainly in training. And if you were to roll out your technology, I suppose that would be replaced with perhaps a gap in training to interpret your technology. So are you planning kind of in parallel some training frameworks or even workshops, or how would you roll this out in practical terms?
So I think it is a little too early to think about rolling out, because this is perhaps the first time it has been demonstrated that it can actually differentiate between a dry bite or a non-venomous bite and a venomous bite. So it's a little premature at this point of time, because it needs more validation. As I said, it needs to be more validated by different people in different settings with wider range of snake species. It needs to be validated. And rolling out is relatively easy in the sense that I was showing some data on inter-observer variability. So there were 3 observers who were totally new to this imaging. They were given actually the processed images. They were given a brief introductory session of hardly 5 minutes, how a hotspot looks like and how a normal image looks like. That's all. With that, they were able to score all 89 images in less than 30 minutes time with good amount of reproducibility. But of course, that processing needs a little bit of training. Even then, that's very easy. That's very easy. So it's not really technically demanding, but only when we start rolling out, we will really know what kind of problems we run into. For that matter, we used a desktop computer for processing, but now we have an app which can be done. The processing can be done on the mobile phone itself. You really don't need a computer actually. You can directly take the infrared images and you can process it right on your mobile phone and you can interpret. And I can even envisage that somebody even devices writes up an automated app which will interpret by itself and it will flag you, say that it is there. There is a difference. So there is scope for technology to improve upon things. You may not really need human interference with so much of improvement in artificial intelligence and all those things on the technology front. You really may not need human interface to process and interpret the image. There is a lot of scope for technology to come in and contribute there. Except the only factor might be they're just making things available and they have to acquire the image in the right fashion. Beyond that, technology can actually take over.
Absolutely. And that was actually going to be my next question. And I thought maybe I'm getting ahead of myself, but I was going to ask you exactly about that. How can AI, artificial intelligence, and sort of machine learning in future, of course, as you explained, this is the preliminary step, but is that the route you would foresee kind of boosting this approach?
Yes, I think AI is really kind of score over human brains when it comes to pattern recognition and image processing. And this is too easy. It's a cakewalk for AI to score such images. I think it's simplest which AI programmer can really think of. It's easy for them to crack these kind of images. It's very easy actually. It's very easy for them.
Okay, we will watch this space then. So we're coming up towards the end of our webinar. We do have a couple more questions, so we'll try and squeeze them into the last few minutes. But
sure.
So just I'll start with Cameron Rafiq's question. Cameron's actually from the ISNTD. And Cameron was asking, can your system be recalibrated or applied to different but appropriate diseases? I suppose not necessarily within NTDs, but other bites and so forth.
Yeah. So is there is the question over? Shall I respond to it?
Yeah, please.
Yeah. So it all depends upon. So here the advantage of using I showed the initial study report by Medeiros et al., where they actually used a really high-end thermal imaging device. It is a very good, very high resolution device. Compared to that, the point of care device which we used doesn't have that high resolution, but it is good enough for the purpose which we are trying to do. You really don't need a very high-end thermal imaging camera which is used for other applications. You really don't need that. So ultimately, the device you acquire depends upon the kind of application you are looking at. If you are trying to diagnose some skin lesions or something where you needed a very high resolution image, people use it for multiple purposes. People have used it for diagnosing, differentiating whether breast cancer, whether cardiovascular disease prediction, whole lot of applications people have used. But if you are really interested in making absolute temperature measurements, then the requirements are going to be very exacting. But fortunately here, we really don't need a very high resolution thermal image either. And we have a contralateral, the limb on the other side to compare. So that makes your job very easier. You really don't have to be technically very exacting in terms of environmental conditions under which to measure things. So the availability of a similar thing for comparison right inside the same image makes life easier for us. So this is a special case it may not afford that freedom in every case possible. But and this is not the first time either that infrared imaging has been tried for medical applications. Whole lot of applications have been involved. So this is not the first time it's being done. So it's all up to the kind of it all depends upon the kind of application which we want.
Fascinating. That's really fantastic. Thank you. And so perhaps just to conclude, we've got another question from Stephen Bramer. So moving away a little bit from your approach, have your organization isolated the active ingredients in traditional medicines used by traditional healers?
No, we are not currently looking at this. So honestly, I have absolutely no idea of what they use. Yeah.
Okay, well, we'll have to have a different connect to answer those questions, Stephen. And a final question, Cameron Rafiq, what are the partnerships that will really impact this technology? Will those partnerships be local, i.e. the digital economy in India? Good question, which is huge, of course.
So the kind of partnerships is, as I said, that there has to be, in terms of in the medical fraternity, there have to be people who evaluate and validate technology in different geographical settings, different snake species. That's one thing. And there could be partnership with technology partners who make this imaging device more affordable. And the technology applications, somebody even come out with AI, artificial intelligence programs to interpret these images. So, and even if this technology funders, if some funder pitches in and kind of sponsors the thing, the cost can be underwritten actually. Just like we have in TB diagnostics, we have this gene expert MTB for diagnosis. It's actually a costly technology. But there are funders who underwrite the cost. So it has become widely accessible and affordable. So like that, if this is the technology we need to do this, then it can be done. It can be done. So it's not that it's not impossible. It's not an insurmountable problem. So cost is so it's a relative thing. It's a relative thing. So first of all, its validity has to be tested and proven, because this is perhaps the first study where it has been empirically demonstrated. So because anybody, we know in medicine that whenever something is brought out for the first time, there is what we call as an optimism bias. So it has to be reproduced in the hands of other people. It has to be validated. And more importantly, as I said again and again, that different diverse species of snakes, what happens with bites by diverse species of snakes, we really have to know. So that's a medical part of it. The non-medical part of it is the technology front. How can we make these imaging devices more affordable and accessible in the remotest areas? And whether we can do away with the need for the human element in image processing and interpretation by bringing in AI. These two are the things which I can readily think of.
Well, Kadir, thank you very, very much. It has been a really exciting session. As you say, this is just kind of the first step in many directions and partnerships that will be needed, and we'll certainly be watching this space and hopefully have the chance to hear more from you in future as the project moves along. Stephen and Ivana were both saying, just going back to the traditional medicine, something worth exploring as well, as and when you have the opportunity. But again, we'll really thank you so much for having given us an hour of your time today to share this with us. I've put the link to the published paper, which came out recently in PLOS NTDs. And for anyone who would like to have a copy of that, I'm just going to share the PDF. I think you can download that directly from your screen. Kadir, you've got a lot of people saying thank you very much. Adrian Hopkins, thanks. David Williams, thanks everyone. Very interesting to listen in. Anik Monjo, and hello, Dr. Monjo. Nice to have you here today. Thank you so much, Professor Kadiravan, for this very interesting presentation. And to ISNTD, well, you're welcome. It's always our pleasure. and many, many more. And thank you to you all as well who've tuned in today. We've had Mangala Devi, John Bosco, and many, many more. Again, I can't mention everyone, but lovely to keep joining you all once a week at the very least. So we are now going to meet again next week. It's not going to technically be a Connect. We've got our annual ISNTD Festival, which will be a conference over 2 days where we bring together creative approaches and global health. And that includes film, photography, but also gaming, apps, anything creative. So as and when your app's ready, Kadir will be more than happy to include that in our festival and hear all about it. But in the meantime, we wish everybody all the best, sending our best regards from London. Keep well, and let's keep in touch. And thank you again, Kadir.
Thank you, everyone. It was indeed my pleasure to be here and share my findings with you and interact with you. And thank you, Marianne, for this wonderful opportunity. And stay safe in these COVID times. Take care.
Yeah.
All the best.
All the best.
Bye-bye.
Bye-bye, everyone. See you next time. Bye.
Bye.